about the accuracy of melanoma diagnosis and melanoma detection, a 10-year multicenter survey. You see a lot of authors. And what do you see here? This is the number needed to excise to find one melanoma. So here you see 10 lesions have to be excised, or 12 lesions have to be excised to excise one melanoma. And this is these are the specialized centers, those who use dermoscopy and monitoring, and these are the non-specialized centers, those who do not use dermoscopy on a regular basis. And you see that the number needed to excise is much higher in this group. So they have to excise a lot of more lesions. Why? Because they don't know so much about the subject. But what is more important is, here are the age groups, and here are also the number needed to excise, and per age group, and also specialized centers and non-specialized centers. And here are the children, 10 years old and younger, and you can see that the number needed to excise one melanoma is incredibly high in non-specialized centers, red, but also in specialized centers. We excise 200 lesions and more in children to find one melanoma. This is inappropriate, I think, and is triggered by fear, maybe by mothers, but it's inappropriate. Too high. Now, melanoma in children are rare, and we have to take notice of this fact that it is rare. How rare are they? The good numbers are from the US, because they have a good database. And the National Cancer Database in the US includes 75% of all diagnosed malignancies. And this is from nearly 20 years, 1985 to 2003. And you can see in 20 years in the US, only 117 melanomas were diagnosed in children between 1 and 4 years, and only 172 in children between 5 and 9 years. The US has 300 million people. You know what this means? Most of you will never see a melanoma in a child, yeah? But we excise a lot of lesions in this group. Overreaction leads to overdiagnosis, and this is also true for children. We know the problem of spitz nevi in children. Sometimes pathologists are insecure, and this is also a dermoscopy for spitz nevis, and the pathology also looks frightening. And what do the pathologists do then? They sign it out as an atypical spitz nevis because they are not sure, even if it is a child. But when you're confronted with an atypical spitz nevis with the diagnosis, what do some pathologists and even some clinicians recommend? They recommend a diagnostic lymph node or sentinel node biopsy to see if it's a melanoma or a spitz nevis. And if they find melanocytes in the lymph node, then they can prove that this is a melanoma and not a spitz nevis. This is what is done several times. But the question is, if you find melanocytes in the sentinel lymph node, does this really mean that the lesion, that the original lesion was a melanoma? Well, you can also have nevus cells or nevi in lymph nodes. Mostly they are at the capsule and you can differentiate it easily, but sometimes it's not so obvious. And here are examples. But this example here shows you a lymph node. Here the capsule is covered with melanocytes, but also there are melanocytes in the lymph node itself, in the subcapsular space. So now the problem is, if this was a child and this lymph node came from a child with an atypical spitz nevis, what would you have to say? You would have to say this was a metastasis. Now what is the problem in this case? This case did not come from a patient with a melanoma. It came from a patient with breast cancer who never had a melanoma. Yeah? So what I want to say is that the biologic significance of positive sentinel nodes in melanocytic lesion does not necessarily tell you that the lesion was a melanoma. Or in other words, this also may be overdiagnosis. If you find a positive sentinel node in a child, it doesn't necessarily mean the same as in an adult. And we may label children with metastatic disease, which the children don't have. Now what about special sites? Special sites from a clinical and dermoscopic point of view. One special site, acral sites. We overdiagnose melanoma on acral sites. Why? Because many congenital nevi on acral sites look like melanoma and frightening. This is a typical example clinically, dermoscopically, although it has a parallel furrows pattern at the periphery. Who would leave this lesion? Iris is very brave, yeah, but most of you would excise it. I was also not brave enough to leave it. I excised it, and here's the histopathology. And the problem with histopathology in acral cases is, although this is a clear-cut nevus, there are also acral cases that are difficult pathologically, because you may have criteria of melanoma pathologically in acral cases. For example, ascent of single melanocytes in higher levels of the epidermis. A hallmark of melanoma on other sides, very common in acral nevi. Pathologically, also other sides are difficult where you can have criteria of melanoma and the lesion actually is a nevus. Acral sides, genital, interdigenous zones, scalp, breast and milk line, and nail. And I want to show this case here because I know it has, because some of these cases are published. This, for example, what is your diagnosis clinically and dermatoscopically of this lesion? What do you think? Acral lesion, is it a melanoma or is it a nevus? It looks like a nevus. It's symmetric and it has which pattern? Parallel furrows pattern. But you can see this was published as exclusively benign dermoscopic pattern in a patient with acral melanoma. And you can see here the histopathology. Now the question is this really a melanoma? Here, is this really a melanoma, or is this just a nevus that simulates a melanoma on acral side? I don't know, but it is published. And when it is published as a melanoma, what is the problem? The problem with dermatopathologic overdiagnosis, and this may be overdiagnosis, although it's published, we lose our trust in dermatoscopy. Because if we start to excise all lesions, acral lesions that look like this, we can excise everything. And here is another example, and I bring this because it's from Bologna. It's a nail case, and it also has been published. It's a child. And this was a congenital lesion of the nail matrix. And it was diagnosed here, histopathologically, finally, as a melanoma in situ. So what we have, a congenital melanoma in situ of the nail matrix. Very rare, very unusual. The question is it really true? Yeah. And another case has also been published. Here, a melanoma in a 14-year-old, 11-year-old girl, also as melanoma in situ of the nail matrix. Is it really a melanoma in situ of the nail matrix? Should we excise now all melanocytic lesions in the nail matrix of children? Well, again, the study authors admitted that the case has created a heavy discussion among dermatopathologists. And what does it mean, a heavy discussion? It usually means 50% said this, it's a nevus, and 50% said this. But they published it as a melanoma. The problem is, with these cases, we lose our trust in dermatoscopy because of overdiagnosis, of pathologic overdiagnosis that does not fit with the histopathology. This is one case of mine. What do you think, given the cases? This is a 6-year-old boy. If I lose my trust in dermatoscopy here, I would have to do surgery, but I didn't. And this is 1 year later. You see the lesion stayed the same, and it lost this broader part at the basis, so it is a nevus. So don't lose your trust in dermatoscopy, even if there are some exceptional cases. Now, chronic sun-damaged skin is difficult because this has been underdiagnosed for quite years, and historical terms for facial melanoma in situ, but there is also overdiagnosis now. We can diagnose melanoma in situ of the face simple now because this histopathologically will reveal a melanoma in situ, what you already expected from dermatoscopy. It's gray, and gray in the face is not okay, flat lesion. And here is the histopathology, single cells and no nests, only single cells histopathologically. But enough for the dermatopathologist to make a diagnosis. The problem is not every proliferation of single cells on sun-damaged skin is melanoma in situ. Now there is overdiagnosis. You have to differentiate melanocytic hyperplasia or chronic sun-damaged skin from